Dr. Jeff Lancet. I'm the chair of the Department of Malignant Hematology at Moffitt, and I'm here at the American Society of Hematology annual meeting in New Orleans. And I'm joined by Dr. Kenrda, who is the Director of Clinical Research within our Malignant Hematology Department. And Kenrda has a research focus in myeloid malignancies. Kenrda, you have led a trial focusing on an interesting new antibody-drug conjugate that appears to have unique activity in AML. Could you talk a little bit about that?
Certainly. Pivekimab, it's also known as IMGN 632, is an antibody-drug conjugate. It's targeted against CD123, which is expressed on the majority of AML blasts, as well as leukemic stem cells, but not typically seen on normal hematopoietic stem cells. And so we've been studying this drug for quite some time in relapsed refractory AML, first as a single agent and then moved it into a combination with azacitidine and then with venetoclax, and now with the triplet of azacitidine, venetoclax, and pivekimab. It's taken quite some time to really find the most appropriate dosing for all three drugs, but it looks like a really, at this point, safe and effective combination in the relapsed refractory setting. We've studied it in over 70 patients at this point in the relapsed refractory setting at various doses, with fairly encouraging response rates in some pretty high-risk patients, including those with TP53 mutations, those who have relapsed post-transplant, and those with other high-risk mutations as well. So with that data, we then decided to move the triplet into the frontline setting, where we now have good data on the first 10 patients that we've treated, where we've seen a 50% complete response rate in those first 10 patients with 30 to 40% MRD negative CRs. So definitely encouraging data so far that we're looking forward to expanding out into a much larger frontline study.
Another question, one of the biggest controversies in AML therapy these days is the utility of low-intensity therapy versus higher-intensity therapy with the advent and approval of azacitidine or HMAs plus venetoclax. You've led an investigation to help understand the difference between the two regimens and whether there could be any ability to achieve the same endpoints with the same regimen with potentially less toxicity. Could you talk a little bit about that study?
Yes, absolutely. So one of the compelling aspects of some intensive chemotherapy regimens are the excellent outcomes that we see in our patients that we then send on to allogeneic stem cell transplant. But the question has always been, what are the outcomes in our patients that we treat with lower intensity regimens that we can then send on for transplant? So those two regimens have never really been compared head-to-head in that regard. So we decided to look back at our patient populations, which we have quite a large database at this point of patients treated with intensive chemotherapy and those treated with lower intensity HMA plus venetoclax. And what we found is, although there were less patients that have been sent on to allo transplant after being treated with lower intensity regimens, at this point the outcomes do appear quite similar between the two groups, which suggests that HMA-VEN in the right patient population can certainly be a reasonable bridge to transplant with potentially less toxicity than what we see with higher intensity chemotherapy. I think there is a lot of potential bias looking at this from a retrospective setting, and we need to delve into more of the factors of what makes somebody choose higher intensity versus lower intensity treatment up front. But it also is really encouraging to see that we can still get good outcomes in these patients.